Macrina, you're not wearing green.
It is green. It's greenish. It's a teal green is what my husband just said.
See, Dr. Staub's in green. The pediatricians love to dress up. Any holiday, there's an excuse.
I just don't want to be pinched by my kids.
Oh.
Oh, I got pinched by 13-year-old today. It was fun.
Oh, did you
I
get
got a green stem on a flower.
That worked.
whatever works for you?
It's a teal green. I trust my husband.
We do too. Well, it is 12 noon. We are going to get started. Welcome, everybody. It is March 17th, 2022, right? If you're watching a recording of this, a lot of this information might be out of date, so be sure to check on cdc.gov or contact us at TAPI, and we will make sure that you get the accurate information. And we want to wish everybody a very happy St. Paddy's Day. It is the day when we are all Irish and we are all a little luckier than we were yesterday. So we want to celebrate any of these like cultural holidays, and ethnic holidays are all about food. So we thought it would be fun to celebrate by seeing if you all are cooking any Irish recipes or doing any Irish food. So go ahead and send us your recipes in the chat. We'll give prizes to the first 5 people that tell us what you're eating and how to make it. Even if it's something simple like green eggs and ham. And we have a pretty jam-packed day today. Dr. Nick's gonna talk us through some COVID updates. Last time we met, we reviewed the ACIP schedule. It had just been released that morning, so we still had some questions about some of the footnotes. Macrina's done lots of research, so she is going to give us all of the updates on those footnotes, and then Jen Tinney from TAPI is going to do billing. So how can we actually get paid to keep doing vaccines? So, right, and Dr. Nick, we are going to turn it over to you while we look at people's Irish recipes, and you can tell us what you are cooking too, if you want.
Sure. Thanks, Rebecca. I was having a great Friday morning until Rebecca gave me a lot of assignments on what to cover on this call. So I'm going to share my screen if that's okay. Let's see. All right, so just by way of a quick update where we are in Maricopa County. So this is our epi curve, and it has dropped very nicely to transmission levels, new cases being reported similar to where we were back before the Delta surge. So we're very relieved at County Public Health to see those numbers. In terms of our deaths, hospitalizations, likewise, those have also been coming down. Our hospitals are still very near capacity as they seem to be backfilling those COVID hospitalizations with a lot of other hospitalizations. Some of those are probably delayed care or people who just weren't able to get into the hospital because of the hospitals being overrun with COVID. We like to share these charts, especially with this group, as they're related to COVID vaccine. So this is unvaccinated versus fully vaccinated individuals. This looks at cases of COVID-19, so essentially breakthrough cases versus cases in unvaccinated individuals. And you'll see that when you have a high surge like we had during Omicron, the two will get farther apart, and then when we have low transmission like we have now, they come closer together. But at this point in time, with low transmission, you're still 3 times more likely to test positive for COVID if you're unvaccinated than if you are fully vaccinated. And for hospitalizations, you're just about 12 times more likely to be hospitalized if you are unvaccinated. And for death, you are 30 times more likely to die if you are unvaccinated versus fully vaccinated. So again, we always like to point out how remarkably close to zero the fully vaccinated line has been with COVID deaths, and continue to use that as a way to encourage people to be vaccinated if they are not. And with the decline in cases, there is a delay in the decline in deaths, but we have seen that likewise falling pretty quickly over the last days and weeks. Many of you may be aware that the CDC has given a new metric for measuring community transmission. It is the COVID-19 community level. This is different from community transmission, which was looking at case rates and percent positivity, which many of you, especially in the healthcare setting, are familiar with, as that has directed a lot of the infection control procedures and policies that you have in place in healthcare settings. The community levels really apply to the broader public, not to healthcare settings. And so these take into account not only case rates, but also how COVID is impacting the community, mostly based on hospitalization data. Taking into account really severity of disease as much as how many cases there are. This is the second round. These levels are released once a week. And so ever since they were released, Maricopa County has been in the medium level. The rest of the state seems to be moving in that direction. And you can see much of the country is now at a low level. And this is very basically kind of what is prescribed at each of those levels. Notably, the difference is the recommendations for masking in public. At a high level, the recommendation for masking in public applies to all individuals, regardless of vaccination status. At the medium level, where we stand, that mask recommendation kind of drops off and really is only intended for those who are at high risk for severe illness. And it recommends that you discuss that with a healthcare provider as to kind of what your risk is and whether or not you should be masking. At all levels, there's the recommendation to stay up to date on vaccines and to get tested if you are symptomatic. Again, access to rapid antigen testing is widely available now, very different than the setting we were in just a few weeks ago. And as well as flu testing, because we are seeing a slight uptick in the amount of influenza A that is circulating. So you want to be able to distinguish between COVID, flu, or other so that you can get appropriate treatment if you are eligible. Again, these community levels that apply to the public, they do not change isolation or quarantine guidance, so that remains the same. So if you have been exposed to someone with COVID-19, or if you test positive for COVID-19, you should still isolate, you should still quarantine and stay away from others according to those guidance. And so that guidance from Maricopa County Public Health still is in place and is linked there for you. And again, these community levels do not apply to healthcare settings. So healthcare settings should continue to use the previous community transmission rates. Those transmission levels still put Maricopa County at a substantial level. So most notably at a substantial level, there is still the recommendation that healthcare workers wear a mask during any patient care. And eye protection is still recommended in areas where substantial and high community transmission are happening. So that would still be the case here in Maricopa County. If our case rates get below 50 cases per 100,000, then that would change that recommendation for eye protection. And so that would be something to kind of look forward to in your settings if that applies to policies that are in place. Rebecca wanted me to address vaccine effectiveness in kids. So a lot of news out, a lot of data being shared with FDA from the pharmaceutical companies. I found this article that was out in the New York Times to be really helpful to read as just a way of thinking of talking to parents who are considering getting their kids vaccinated. Again, During Omicron, what we saw was that the vaccine effectiveness for the mRNA vaccines, specifically Pfizer, fell in those youngest age groups. We know that Omicron is more transmissible, it's more contagious, and we know that vaccine effectiveness wanes over time after you've received your 2 doses. So again, it's not surprising to see that there were more cases during the Omicron surge in kids who were fully vaccinated. So that drops that effectiveness level. What we really need to continue to look at is how well do these vaccines prevent hospitalization and death. That is their goal. That is why we are vaccinating. It's not to prevent any COVID-19, it's to prevent severe outcomes. And so we really need to continue to talk to parents about that and push that piece of the news and not just that overall lower effectiveness rates. Those younger kids who are now being vaccinated, like adolescents and adults, will likely be recommended to have a booster dose, so to have a 3rd dose in order to achieve kind of a maximum effectiveness. And so one of the things that I really want to communicate now that we're at this kind of lull in transmission and cases are low, I think there are more discussions around, well, why would I get my kid vaccinated now if the effectiveness is lower and there's not that much COVID-19? Well, the reason is because it takes a couple of months to get your kid fully vaccinated. These are multiple dose series. And so if you wait until the next surge and cases start going up, then you may not have your kid protected in time to prevent, again, severe illness. There was a new MMWR that was just out on the 15th, looking at hospitalization of infants and children ages 0 to 4. And the hospitalization rate of kids 0 to 4 was 5 times higher during Omicron than it was during the Delta surge. So again, COVID-19 is not the COVID-19 we first saw years ago that seemed to spare young kids. It has changed and it is affecting young kids. And we're seeing hospitalizations. We need to get those kids vaccinated, and the sooner we can do it, the better protected they will be when and if we see future surges. Okay, a couple other things here. Macrina, I don't know if some of these were things that you intended to cover. Some of them I don't know anything about, so I will defer to you. But the Johnson & Johnson expiration was extended to 6 months. So if you have Johnson & Johnson vaccine on hand, be aware that that has been extended, and there's a link here to a vaccine checker where you can enter the lot number and it will tell you what that new expiration date is. There's also really cool news out about Johnson & Johnson, looking at how it's comparing over time to the mRNA vaccines. And as we see some waning vaccine effectiveness of the mRNA vaccines, as we see new variants, Johnson & Johnson vaccine is actually holding up pretty well relative to those vaccines. So it'll be very interesting to see where that goes. I think it's really encouraging for the international community that is planning on using Johnson & Johnson for their vaccination efforts. Anyway, it's just kind of interesting news that's just popped up over the last couple of days. For moderately to severely immunocompromised folks, again, these are individuals who should get a 3-dose primary vaccine series with the mRNA vaccines. So that's just 3 doses in their primary series, not a 2-dose series with a booster. So their primary series is 3 doses. They should then get a 4th dose, which would be their booster dose after 3 months. So some of the intervals between the primary series and the booster doses have been changing, have been decreasing. And so just be aware that for those immunocompromised folks that they should get that booster dose after 3 months. And then also be aware that Evusheld is the prophylactic monoclonal antibody. Monoclonal antibodies and the COVID-19 antiviral pills are in relatively good supply around Arizona. And so for individuals who meet this, meet these conditions, they should also consider getting the infusion of Evusheld. Let's see, mRNA vaccines also have been updated to have an 8-week interval in the primary series at the physician discretion. And this is really how we're talking about this from public health. This still the recommended interval for Pfizer and Moderna is still that 21 and 28 days. And that's really what you should plan on scheduling. But for parents, particularly of adolescent and then young adult males who are concerned about the risk of myocarditis, they could consider delaying that second dose out to 8 weeks. And that has been shown to decrease the risk of myocarditis. Remember, you're decreasing the risk from a very, very small risk to a very, very, very small risk. So again, if you're concerned about whether or not you're going to get that patient back for that second dose, again, I would try to just get that second dose when you can. But again, for families who are particularly concerned about that side effect, pushing it out to an 8-week interval will may help them. The Pfizer purple cap extension, that's the one, Macrina, I'm going to leave to you in a second to talk about, because I don't know the particulars about that, or if you want to come off mute. Do you have?
I think Jennifer Tinney, I do not have the specifics on that.
Okay.
Because honestly, we've used up all of our purple caps. So I think Jennifer, you might has the information on that. Maybe she could just put it in the chat.
Yeah, I can do that.
Perfect. Sorry for not being prepared on that one bullet point. And then the last thing I wanted to just address is there's news out about consideration for a second booster dose for individuals 65 and over. So I know we've already started to get some inquiries at our vaccination events from individuals 65 and over who are looking for that second booster dose. Again, that data is pending review by FDA and CDC, but it is probably coming down the pike here. A few more things and I will stop talking. One is do not delay to vaccinate after infection. We are hearing from the community that there are some providers out there who are still kind of sticking to that older recommendation of waiting 90 days after an acute infection to vaccinate. The current recommendation is to get vaccinated as soon as you are done with isolation from that acute infection. So don't delay. If you're due for either a vaccine in your primary series or a booster, you should get it as soon as possible after that isolation. There's been good studies to show that getting that vaccine can help prevent long-term COVID symptoms after an acute infection. So definitely get that vaccine. And then there's also no longer any delay after monoclonal antibody infusion to vaccinate individuals. They should be vaccinated as soon as they are eligible. And then I included here, just for anyone who needed the updated guidance from CDC, here it is, vaccinate as soon as possible after an infection. And then the last thing is COVID vaccine co-administration. It's okay. There's really no maximum number of vaccines that an individual can receive at one time. And what I like to say is make the most of the time you have with a patient in front of you and get them all the recommended vaccines that are due at that time, including COVID vaccines. And again, this is a change from the beginning recommendations with the COVID vaccines that they wait 2 weeks to receive other vaccines. That has changed. It is now okay to get any other vaccine at the same time as COVID-19. I think that's it.
That was a lot.
It was.
Sorry for telling you I needed all that half an hour ago.
It's okay.
So I'm glad that you were watching your chat. Otherwise, we would have just asked you the question and watched you fumble through it, and that would have been fun too. So, anybody have any questions for Dr. Staub? Oh, go ahead.
Well, I'm just pulling up the chat, so I don't know. I see a bunch of stuff in here, but
Well,
probably...
we wanted to remind you it's not Friday, it's Thursday, but we made a joke that, you know, those doctors.
Did I think it was Friday? Did I say Friday?
You did? Yeah, you said, well, it's a Friday. We just assumed you were a doctor doing a long weekend.
Yeah, it's a relaxed life. It's a relaxed lifestyle for me.
We would love to hear this idea, this co-administering vaccines. We're having people show up at our vaccine events that are saying that their doctor told them they couldn't get the COVID vaccine. And some of them have said that they go to FQs. So if there's any policies that your offices have to not co-administer, if you could just let us know. We're just trying to get to kind of the bottom of it. We can certainly educate all the offices and all the doctors and remind people that you can co-administer. But if there's some other reason why you're not doing that, we would be interested to know. We know sometimes it has to do with billing or a workflow change or whatever. Like there's lots of reasons why those recommendations, you know, are told, like the wrong thing is told by to patients. So. Or interpreted by patients. All right. Well, if you can hang around, we'd love to hear. We would love to keep you around, Dr. Staub. We also, before we jump into Macrina talking to us about the footnotes for the ACIP schedule, there's these palm cards that years ago we had administered. So if you've been a nurse or an MA, for many years working in vaccines, these might look familiar to you. They're little laminated vaccine schedules that you can put in your subs, just in your pocket or hang, you know, keep kind of handy in drawers in the office. We are wondering if having that would be helpful for you or not. So please just participate in that poll. Because if it would be really helpful and you think that you use them, then we'd love to be able to order one for you and give them out to everyone at some point, you know, at some point throughout the year. So Macrina, I'm going to keep this poll open, but why don't you tell us everything you learned about these footnotes?
Okay, yes, I'm unmuted. Okay, yeah, the footnotes really weren't as intimidating as I thought they would be. So for the childhood vaccines, they did add dengue vaccination to the schedule, which I think was probably the most confusing one on there. I'm going to give you a little just brief description of what dengue disease is because I found it fascinating. I didn't know a darn thing about it. So the recommendation is to immunize kiddos 9 to 16 years of age living in a dengue endemic area. But the children must have laboratory confirmation of a previous dengue infection. That is because the manufacturer of the vaccine has identified that if children who have not previously had a case of dengue get vaccinated, that if they do they have a very high chance of getting the disease, and the disease can be very severe. So they must be a confirmed laboratory confirmation of a dengue infection. It's a 3-dose series given at 6, 0, and 12 months. And we did attach the Ask the Experts, because I think a lot of us who planned this presentation had a lot of questions, and they answered every single question except for one. And I will answer that for you after the next slide. This is really the areas where dengue is endemic. It's Puerto Rico, American Samoa, US Virgin Islands, Federated States of Micronesia, Republic of Marshall Islands, and the Republic of Palau. I did send to CDC a question about, we know that a lot of our folks live along the southern border and they make frequent trips to and from Mexico. Children could actually live throughout the summers and several months in areas where dengue is endemic. And according to CDC, none of the 50 states are going or planning on implementing dengue vaccination programs. So the answer is we will not be immunizing within the 50 states. Dengue is a vector borne caused by mosquitoes. It's caused by 4 distinct but related viruses. And you can be infected with every single one of those viruses, which means you can get a total of 4 infections. Usually the first infection, any infection can cause severe illness, but routinely the first infection is milder, but the second infection is most likely to cause severe illness and hospitalization. That's why you would vaccinate after someone has had the primary infection. So that's just a little FYI on dengue. Again, if you have any other questions, definitely go to the Ask the Expert at IAC, and they have a lot of them answered for you.
But the big takeaway is unless you are starting to open a practice in one of these areas in Puerto Rico, or you're moving somewhere really tropical and nice, you will not be administering dengue vaccine.
Correct.
So changes to HPV.
So there's changes to HPV. They're now recommending it at 9 years of age. The rationale is that if you get the first dose in at 9, then you will definitely be able to get that second dose in sooner. Waiting till between 11 and 12, they've discovered that getting that second dose in might make it a little bit more difficult. So recommended at 9 years of age. Any children with immunocompromising situations should receive the 3-dose series, irregardless of age. And so that would definitely be your docs. I'm taking a look at that kiddo and identifying whether or not they're immunocompromised. And if they are, they're going to get the 3-dose series. And Vaxelis was added to the immunization schedule, the DTA, PIPV, Hib, and Hep B combination. And you know how we love those combinations. Probably we like them just as much as those little kiddos do. So the adult immunization schedule, that actually had the most changes, I think the most significant changes. They're now recommending zoster vaccine, Shingrix, to adults 19 through 49 years of age with immunocompromising conditions. And these would be any, either caused by disease or any therapy that someone is receiving. We're seeing younger and younger folks, especially who are immunocompromised, getting severe cases of shingles. A lot of that has to do with we're just not getting boosted or exposed to kids with chickenpox anymore because the vaccine has been so successful in little ones. Pneumococcal vaccine, there are some changes again. Just when we think we all understood pneumococcal guidance, they went ahead and changed it. It's for age 65 years of age and older, age 19 to 64 with certain underlying medical conditions. Now there are 2 new pneumococcal products on the market. One is a PCV20. If you're 65 years of age and older, you're going to get a single dose of PCV20. Or there's PCV15, and you're going to follow that with PPSV23. Anybody with an immunocompromising condition, you're going to give PCV15 and PPSV23 8 weeks apart. The recommendation is still for immunocompetent folks that the PCV15 and PPSV23 be separated by 1 year. And then hepatitis B, this is a big one for all of us. It's routine vaccination of all adults 19 to 59 years of age. Remember a couple of years ago, they made a lot of recommendations for folks who should be immunized with hepatitis B, anyone who is diabetic, smokers. There was just a long, long list. So they have discovered that the rates of hepatitis B vaccination among those high-risk adults, they were getting missed. Those folks were getting missed in their primary care provider's office. So they just went ahead and did the routine recommendation for all adults 19 to 59 and 60 years of age and older if they're at risk for hepatitis B infection.
So we know the billers are on because they're already asking in the chat, when are these things going to be covered? So what do we think, Jen? Like 3 months usually it takes for them to, I mean, start administering it once it's now been published, start administering it and billing for it. But the payments, how long do you think it'll take them to catch up?
Takes about 3 to 6 months for a health plan to get those codes loaded correctly and not kick them out for inappropriate age range. So hold the claims as long as you can, submit them. You might have to resubmit them a second time for payment.
All right. And Tori had a question in the chat regarding immune compromised for 3 doses, a person who had a diagnosis of MS. Dr. Staub, is there anything else? I see you answered it in the chat. Anything else you want to add?
I would just say, the criteria, and I can pull them up real quick. The criteria for moderate to severely immunocompromised conditions is pretty tight. Again, we're pretty open in our in our practice in public health as to who would qualify for that. If an individual says that they meet the qualifications, then we treat them as such. So if this individual who's newly diagnosed with MS says that they are moderately to severely immunocompromised, then I would go ahead and say that their 3 doses that they've already received is their primary series, and that they should get a 4th dose, their first booster dose, 3 months after their 3rd dose. But if you have any questions, I would defer to the treating clinician who's treating them for their immunocompromised condition.
Thank you. And Macrina, just to double check for Valerie's question here, do you know if all the mRNA vaccines have to be out of the fridge for 30 minutes to get to room temp before adding the diluent or drawing up to administer for the great top?
No, they don't have to sit up for 30 minutes to get to room temp. It's just getting to room temp. So, yeah, and it's, yeah, it doesn't have to sit up for 30.
And Jen, can you cover that ASIIS question that Julia has here?
Yeah, there used to be a little drop down on ACIIS to record exceptions and cases. So for instance, if you had somebody who already had chickenpox, you could put in a contraindication for the chickenpox vaccine so that it wouldn't show up as a necessary dose or one that was missing. And then there was also a choice in there for a reason that the previous vaccines were invalid. So I'm not sure if anybody who's worked in ACIIS recently, and that was a few years ago when I saw it, do you know if it's still there? So you can flag them as needing additional doses because of, in this case, I believe it's a transplant.
Yeah, and anybody
And I'll double check it.
who wants to, if anybody knows or has some advice and wants to unmute, please do so. Maybe we'll double check for next time too, Jen.
Yep, I'll check with ADHS.
All right. Any other questions about regular vaccines or COVID vaccine? Amy's chatting in the DTaP IPV shows up in ASIIS on our 4-year-olds that they do not meet the age requirement. Can that be fixed? We can pass that along to DHS, right? Have you ran into that too, Macrina?
You know what? I don't know. No one has mentioned it to me.
Okay, well, we'll follow up with you, Amy, if we need more info.
Does it, I guess my question, do you get that big red X next to it if you do administer it and enter it?
Yeah, we get the or it's like it's an asterisk or an X, I can't remember, but it does show up, and then when you pop on it, it says they don't meet the age requirement.
Oh, yeah, and that's gonna drive school nurses and everybody crazy. We'll
Yeah.
mention it to DHS.
Thanks.
All right, well, Jen, tell us how to keep making money, because we all want to keep getting paid.
Okay, I didn't realize it was already my turn. I'm still reading the chat. Okay, billing. A lot of this is going to be on COVID vaccine billing because it's as confusing as it can be, as if billing was the most confusing subject on the face of the earth. They've made it far more challenging with COVID. So I'll talk a little bit about COVID, and I'll throw in some tips to maybe help with routine vaccines as well. But some of the primary things when it comes to COVID, at first they said bill directly to Medicare, not through the Advantage plan. Now that we've been doing that for 2 years and we kind of have that down, they're switching that and saying now you need to begin to bill the Advantage plan. So that's going to be tricky for a lot of practices, but just kind of keep an eye on that. Medicaid, the good news is for COVID, they're paying $83 per dose, which is tremendous considering how much extra effort goes into the COVID vaccine clinics. The uninsured program. So right now, this is a battle with Congress and the budget that didn't pass to put more funds into the COVID response. So far, the funds are not there, which means that the uninsured program, That means if you had a patient who was uninsured, you could bill this HRSA program, and I'll share the links with you guys in a little bit, but it's not many uninsured claims still hanging around. Send them in as soon as you can so that you can still receive reimbursement while that program's going. No out-of-pocket costs on the COVID vaccine. Of course, you can't balance bill the patient or charge them cash. You do have to bill Access, Medicare, the private plan, or HRSA, and hopefully we'll get that HRSA program back for those uninsured patients, and we'll see what happens with that next. You want to flip to the next one. There we go. So in honor of St. Patrick's Day, and I saw someone is fixing corned beef today and cabbage, so there's an ICD code for that, just in case you overdo it a tad. Poor little green guy. But really next I'm going to go through some of the COVID billing codes because they are so confusing and there are so many. As you know, for typical vaccines, we have the administration codes. It's based on age and whether or not you've given a combination vaccine, and that's about the extent of it. Are they vaccine or are they? However, when it comes to COVID, we have vaccine and dose specific codes. So for instance, for Moderna, we have the Moderna vaccine code, which you bill at 0, just like you do for a VFC code or a VFC vaccine. And then you have the Moderna first dose administration, second dose administration, third dose administration code, and Moderna booster codes. So you have the half dose vaccine code and you have the Moderna booster code separately. And then you can see from the on the next slides that we've also got the same thing happens with J&J and begins to happen with the other vaccines as well. For J&J, we did get that question answered from last week that CDC just changed the recommendation that they prefer the mRNA full dose booster. So if you've had someone who had a J&J vaccine, now it's time for their booster, give them the full dose of Moderna instead of the half dose. Everybody else still gets the half dose.
And that's new.
Then
That's
brand new.
yeah.
Yeah. Last week, I think they changed that. So originally, when we talked last month, it was half dose, but they were talking about changing it to a full dose, and they did. This is one of the, if you blink for a second, you kind of miss the new update, but we got that one covered. So on the Pfizer codes, of course, we've got the full series, the purple cap. Most of the purple cap Pfizer, this is the 12 and above, the first one that they put through. Most of those are gone in Arizona. Most places don't have any left. We were surprised to find a few clinics in the last week that did have the purple cap, and since the expiration's been extended, you can go ahead and use that, and these are the codes for those. Now, where this gets really confusing, so as we go from purple cap to gray cap, the FDA fully approved the purple cap. It was no longer under the emergency use, and they gave it a brand name, that Comirnaty. Somebody's gonna, Macrina, you're gonna have to help me. What was it?
Comirnaty.
I keep thinking Comirnaty. Comirnaty. Yes. So under the purple cap, you could bill it under the brand name of Comirnaty. But the other versions of this were still under the EUA. So if you go to the next one, the kids vaccine or the gray cap vaccine that came out after the full approval, the FDA has gone ahead and said, yes, they'll consider the gray cap as fully approved, not under emergency use, so you can call it Comirnaty. However, the AMA and the health plans caught up. You still have to bill the gray cap and all of its codes using the Pfizer BioNTech name as if it were under an EUA. So this is another glitch that we're beginning to see. So those of you who are getting denied claims that says it's given out of the age range, or this vaccine is not approved for, say, age 12, 13, or 14, It's because you've used the gray cap and you build it with the comorbidity name, which the health plans don't recognize. So again, like I said, they could not have made this any more confusing than they have, but it's very difficult to bill this and get those claims paid without a whole lot of glitches. So the orange cap is for the kids. This is 5 to 11. It is still under an EUA and has not been fully approved. And all that means is we're waiting for the efficacy data to come in. Like, how many kids did we give it to? Are they covered? Are we seeing a decrease in the number of cases? That's the only difference between these vaccines. It's the same formulation, the exact same vaccine, just that the very first Pfizer that came out, the FDA's had enough data to look at it to put it through for full licensing approval and giving it a brand name. So for the rest of these, in the next few months, we'll begin to see that they're fully FDA approved. But as you can see, all of the codes are here. You can share them with everyone in your practice, just so you guys can kind of get a handle on those. The one thing that I will say, like for this Medicare third dose versus booster, make sure you're documenting anyone who's immune compromised and the reason that they're getting that third dose. We're seeing denials of claims for this person was not really immune compromised and shouldn't have gotten a third dose. But you're taking the patient's word for that. So if they say that they're immune compromised and need that additional dose, just document that patient stated they're immune compromised and qualify for the dose. For that booster dose, make sure that you bill it with the booster code and not as a third dose, or you're going to run into this immune compromised problem. The other thing that
you have a
what was
question in the chat. Is there a different CPT code for the booster for Moderna when given to a J&J patient?
Yeah, because this was a change that just happened last week. Chances are there's going to be a code in the next couple of weeks for a full dose Moderna booster.
Yeah,
You're
so
right.
we'll get that next time.
Yeah, until then, I think use first dose Moderna or second dose Moderna code, probably second dose code, and you may see it get kicked out. Because we are also noticing that, say, a patient went to a pharmacy that billed for the first vaccine, and then they went to one of the pop-up clinics where they were not billing for a vaccine for the second dose, and then you give them the booster dose. Some of those booster dose claims are being rejected, saying we only have record of the first dose given. So the health plans are paying very close attention to which dose has been given and which one you're billing for. They are recommending that you attach the ASIIS record showing that that patient has in fact had the number of doses. Okay. Trying to see if there's any other questions in the chat. Anything coming up with those?
No, you're good.
Okay. All right. So on to the next one. So here are a couple of little differences, and I so apologize for my dog who's barking at my office door currently, trying to tell me that there's a deer in the yard that is making him feel uncomfortable. But a couple of different things. So there's the CARES Act Provider Relief Fund. This was regarding COVID vaccine only. So this is where providers can get reimbursement from the plans and the uninsured programs. You cannot balance bill the patient. You can't bill the patient out of pocket. So if they're uninsured, you cannot ask them for the administration fee, and that's different from VSC. So even though these are both federally supplied vaccines, there are two different policies and rules to follow with that. So for the VSC administration fee, you can bill $21 in Arizona to the access plan. If they're uninsured, you can charge the patient out of pocket, but you have to waive the fee if they're unable to pay. So that's part of, as you sign up for the VST program, that's kind of the policies that you agree to with that. And it's different for COVID. So you'll have to set up your billing systems to make sure that even though it's an uninsured getting a vaccine, you don't balance bill. And if you're giving them a VFC vaccine at the same time, you can bill if the patient is able to pay. So for the next one,
Is that for all vaccines, Jen?
for private stock vaccines for a private plan, if the claim was denied, for instance, or the patient lost their insurance, you can bill them the full cost of the vaccine and all of the administration for it. So that's for privately insured children. For VSC kids, for all vaccines, you can charge that $21 admin fee either to access or to the patient, as long as the patient can pay. COVID is a little bit, it's way different because it was purchased with federal funds, but under that CARES Act, you can't charge the patient anything.
Okay.
So if you have uninsured patients for COVID, you can submit the claim through the HRSA program. They use the Optum Pay that some of you might be familiar with. It's part of the United Healthcare system. They use the Optum Pay system. You get a denial, or if the patient states they don't have insurance, you can submit it to theirs, and the federal government will reimburse you for that $40 admin fee for COVID. There is an underinsured program, so if you got a payment back from a health plan that was, say, $10 instead of $40, you can submit that to the underinsured program, and they'll give you the $30 difference between them. So this is the effort from this federal program to really try to make providers whole. They know that it costs a lot, that it takes a lot of time to talk to people about COVID vaccines. So they want to make sure that your time is compensated for the efforts that have gone into it. These are the programs that are currently under consideration for that budget cut. So hopefully it'll go through pretty fast, and we can save this program. If not, get all those claims in as quickly as you can. The next one. So for those of you who do VFC, you're kind of familiar with some of the ways that you have to account for and record those VFC or federally supplied vaccines. And this is the same for COVID now. So one of the things to do is to scan the NDC from the box instead of the vial, because as you all know, in ASIIS, the inventory uses that box code, that box number to track your inventory. So whether it's VSC or COVID, always scan the box or put the box number in instead of the syringe or vial. And then for VSC Vexelis, use the Merck as manufacturer so that it decrements correctly. And this is all how that information gets back to the CDC so that they know how much we've used in the state of Arizona. And it's how the state of Arizona program kind of tracks the inventory that you have. And they know what doses you have on hand, what you've used, and what you need to order more from. So always record those federally supplied vaccines with a code in your EHR so that when the patient record is sent over to ASIIS, it also takes the inventory off of your total count in the inventory reconciliation side of ASIIS. So again, you bill the admin fee to COVID to HRSA, the uninsured, supplied at no cost, and the VSC patient can be billed to the patient for that admin fee. How many of you all are using standing orders? Are you guys doing them for all vaccines, a couple of vaccines, or none? Just out of curiosity. Because standing orders are the way to go when it comes to vaccines to keep your workflow going. So that's where the physician writes a standing order. Then anytime a patient comes in, you can give certain vaccines to them without having to do a full exam with the patient. So they can come in for nurse-only visits. Oh, great. So some of you have them for all vaccines. You can do them for COVID. A few of you have them for COVID. I suggest at this point, COVID's going to become a routine vaccine pretty quickly, I think, in the next little bit. So we're going to have to start carrying it in pretty much every type of clinic. So to start to work on those standing orders and get those in place, it'll really help that workflow for you all as well. You want to slide to the next one? Great. Looks like most places are using standing orders. That's awesome.
Good.
So this is just a screen capture for your billing side for kind of how you set up that form to make sure that you've got the right ICD-10 code, that you have the right NDC codes from the box. And then sometimes some health plans are asking for an SL modifier. That SL modifier means this is a federally supplied vaccine. Others are not. But this is kind of how you set that whole system up. So share it with anyone in your office who kind of does those steps to make sure that you guys have it coded correctly. And then the next one, we do have some handouts for patients because we know this is confusing in terms of what insurance they share with you, how that insurance gets billed. We get a lot of calls from patients who say, the office, this COVID vaccine is supposed to be free, or this VFC vaccine is supposed to be free, but they're charging this admin fee to me. So we do spend a lot of time explaining the difference between charging for a vaccine and charging for that admin fee. So we've got some patient education materials to help you guys get through that. And the next one. So quickly, I'm going to go through some additional resources. And on the next slide, we have Don't Waste an Arm. This is only for COVID, unfortunately. Right now, the CDC wants to make sure that every patient who wants a COVID vaccine gets one from your office. So we know that you've got these 10-dose vials. It's getting harder and harder. You have some patients who are fully vaccinated, and you might have one in a day that wants a COVID vaccine. So right now, the CDC is saying, don't waste that arm. Go ahead and give the 1 dose out of the 10-dose vial to the patient. And then if you have to, throw away those other 9 doses if you can't find anyone else to give it to. We've asked about single-dose vials. We know you guys would prefer those. But the cost of manufacturing the individual single-dose vials is higher than just manufacturing all 10 doses and throwing those 9 away. So at this point, we have enough vaccine. Never waste an arm. Make sure that everybody who walks through your door that wants one, go ahead and give it to them. The COVID vaccine will not count against your VSC doses, but this same don't waste an arm doesn't necessarily apply to VSC. Make sure that you're always tracking and looking at that wastage for your VSC vaccine so that at the end of the year, you stay above that 5% wastage for that program. But COVID vaccine won't count through that. So this is a little bit about that ASIIS immunization data and inventory exchange. You guys report your patient records and the doses that you've given to ASIIS, and then that gets sent to the CDC, and then they ship the vaccine out to you all directly. And I'm sure most of you have seen all the headlines about the number of doses in the United States for COVID vaccine, certainly, and that's how it's tracked through this whole system. So we know that the inventory system in ASIIS can be a little bit difficult to use if you're not really familiar with it for both VSC and COVID. But again, it's tracked through that whole federal system up and down. I want to hit the next one. So those of you who do carry COVID vaccine, you report to ASIIS, any patient record in the inventory, but also just a reminder that you still have to report to the CDC Vaccine Finder the number of doses you have on hand. So patient record goes to ASIIS, and then once a day you go into the Vaccine Finder and you let them know I have 100 doses on hand or I have 50 on hand. So that's still in play, and I know that there are some offices that have not done that. You might start getting calls as reminders. So just go in and check, make sure that's taken place. Okay, and then I think most of that's left are a few of the tools that ADHS has put together to try to help you guys manage this, knowing it's difficult. There's the Vaccine Matchmaker app. If you need vaccine or you have too much, you can put it up on the app and they'll match you with the site that has the opposite problem. So try to use the Matchmaker app if you need to find vaccine or if you've got some extra to share. And then if you have lost patient records, so patients not sure which dose they got and you're not sure They can use the MyIR mobile app. And then there is also an immunization record request form that's available. So for those of you who are using ASIIS all the time, you can look in directly, or you can direct patients to these two resources to find records if they need to get a hold of them. And then we've got all kinds of stuff available at Happy. If you need anything and we don't have it, we're happy to work with you to put something together to kind of help you through these. We know these are difficult conversations, and it just made it so much more confusing with COVID. And I think that about wraps up my section, right?
It is. I want to make sure, well, if there's any questions around billing, we have time for a couple, and we can keep the line open too. There was one person who was looking for stuff on the Moderna booster, and it looks like that was already posted in the chat, so that's good.
Yeah. Hey, Rebecca, this is Nick. So Jen, I separately emailed you, and then I saw a couple of people had a question here. In the resources, thank you, Laura, that you put up. I've quickly gone through them. I don't see any updates on giving that full dose Moderna as a booster. So just, I think if you
No, it's
saw
not on
that.
there yet.
So it's not in the clinical considerations, and it doesn't appear to be updated in that FDA EUA that Laura linked. It's the full dose for immunocompromised people for the booster dose, but it's still recommended as only as the half dose everywhere that I can find. And I had not heard that yet, which doesn't mean anything, but.
So if maybe it's just immune compromised, so that J&J gets the full dose as the booster.
Yes, that has been the recommendation. I have not heard that following Johnson & Johnson primary, if you get Moderna as a booster, to get the full dose for the general public.
Okay, all right, then we'll clarify that, and that
Okay.
helps because that means we probably don't have to find that extra new code.
Right, and again, I'm not saying that I haven't missed something. I just, if anyone can find that, it would be good to share around.
They usually get stuff up fairly quickly on those clinical consideration page, within the first few days. So I think it was last week, it was on a web program, but if it hasn't been followed up with that, then I would say it's not in place yet.
Okay, I'll keep looking for it. If I see anything, I'll share it around.
All right, thank you.
Thanks. We do at our next month, we're going to talk about empowering patients. So we'd love to hear, we know that you get asked so many different questions and hear every vaccine myth imaginable, but we'd love to hear from you. What are the questions that you're struggling with the most, just so that we can make sure we do a really good job of targeting the presentation next month. And so please put things in the chat for that, or put it on your evaluation. We don't always do an evaluation, but this month we're going to try and do them quarterly. Anyone who completes it will be sent a prize. And Laura, it looks like there's some comments. Someone already tried to do the evaluation. So we'll make sure that we check that.
It looks like it's working. I already got one person finish the evaluation. So just try again. I'll post the link in 1 second.
Okay. Oh, and it looks like I am going to be able to launch this poll. So you'll see a poll here for us to identify what kinds of things that you're struggling with, that we hope that you answer. And you can select all of as many options as you want. We will email you the evaluation too. So if you don't like looking at the chat, or you're listening in on this while you're walking to the exam room for your 1 o'clock patient, that's okay too. You'll be emailed that and still be able to get your prize. So we will keep the line open for just a little bit to make sure that there's no other questions that you guys want to unmute yourselves and ask or put in the chat. Thank you all so much for everything that you do. We wish you all the luck this St. Patty's Day. And just thank you for everything that you continue to do to keep us all safe and healthy. Thank you. All right. See if there's any, I'm digging through this chat to see if there's other questions on here.
Generally, billing is not the most exciting topic.
I know, it's always boring.
I know it is, but we all have to make sure that everybody gets paid, you know.
Yes.
We don't want to do this for free.
Oh, that's in, Julia's saying in the chat, they're starting to hear that getting the COVID vaccine gives you COVID. I haven't heard that one yet.
I haven't heard that one yet either.
Not surprising that it,
I guess I'm kind of shocked it's taken this long to get there.
Tori's saying she's hearing that too.
Well, and then I've been hearing more and more that it's not a real vaccine, that it's, you know, they compare it to MMR as a live virus, and they say it's not like MMR when we were kids, so it's not a real vaccine.
Hmm.
Oh, COVID vaccines will give you HIV. You know, remember there were rumors about that with HPV years ago, that vaccine was going to give people HIV.
I guess, because, and polio.
Vaccines are amazing.
Yes.
All right, you guys. Well, thank you. I will
Thanks, Dr. Nick.
see y'all later. Yeah.
Thanks.
I realized I'm working at PCH tomorrow. I think that's why I felt like today's Friday. It's my county Friday.
Yeah.
Have a good one.
Thank you.
Thanks. You know, though, I also think that it's when you say HPV and you say HIV and you say all of that really fast sometimes, and people aren't, I think in their mind, they hear HIV.
Mhm.
Well, in the beginning, that rumor started with the polio vaccine because they said it had something to do with like a simian HIV virus that was used as part of the research when they were putting together the polio vaccine, and so that it caused HIV. And then it went to HPV, caused HIV, and now COVID. So I don't know how those are coming across
Mhm.
so long.
It's hard because all of that, I think we really don't understand how our immune systems work and how our bodies work. I mean, we're not really taught that stuff well, I don't think.
Well,
So
and,
it's hard, it's scary, you know?
So you have like 5 minutes in the exam room to explain the entire immune system and how it works and how this simian virus that is HIV-like-esque isn't going to, it's, you know, it's a hard conversation to have, especially when your best friend, you know, who you trust and have known for 40 years tells you that.
Right. Anybody have other questions today? We're easy today. People are ready for their green beer and their corned beef and their cabbage and their soda bread.
I know these recipes were good. We're gonna have to.
They sure
Try them all
were.
out.
I'm gonna try Laura's recipe later.
Macrina wants the cocktail. All right. Well, let's
Adult
go ahead.
beverage.
I think we'll sign off for this month. Oh, 19 to 59. Do they need additional Hep B now? Even
No,
if they have their-
once you have the 3-dose series, regardless of when you got it, you do not need to repeat it. It's only the 19 to 59 years old who have never been vaccinated. But take a look at that record, because a lot of those folks may have only had 1 or 2 doses. They still need that 3rd. Do not need to restart, just make sure that they complete the series.
And if they don't know and it's not in ASIS, because your 48-year-olds will not be.
No, if you don't know, immunize.
Okay.
Adults are the same as kids. If you don't know, immunize.
Beware. So. Do you see what the dental school told her?
I've heard that a couple of times too.
So you know what they're doing is they're going ahead and they're doing post-serology screening on nursing students, dental students, medical students, all of those students. And if they come up that they can't detect, they're sending them back for an additional dose. There is no recommendation to do that, but schools are doing that. So we've been administering additional doses so they can go to school. But CDC does not recommend that. There are people who just don't, absolutely correct.
Any other questions? All right, well, I think we'll sign off till next month and we will look forward to seeing everybody. Try to get all your MAs, like lots of people talk to your patients about vaccines. And next month, we're going to be talking to families about vaccines. So hopefully we get lots of new folks to sign on and hear tips about how to empower people. And thank you all so much.